Great, everyone. So I think I know it was a very brief break, but hopefully you've had a chance to stretch your legs if you needed to, and had a chance to answer the poll questions. Just to welcome everyone back for the second half of our research presentation today. I know certainly I found those first two talks really fascinating, and great to see the progress that's being made in new measurements such as the FOT technique. So very exciting. So thank you very much. So Wendy, I'm not sure if we had enough responses to share the poll results to give us an indication of where people are joining us from today, or will we do that at the end of the meeting? Great. All right. So firstly, I'm not sure if all of you can see how many participants we have today, but fantastic to welcome 124 people on the call today. Huge numbers given how busy everyone is. So many thanks. And as you can see, hopefully you can see on the screen that we've got the majority of people from Melbourne, but great to see as well some attendees from regional Victoria, Tasmania, South Australia, New South Wales, Queensland and the ACT. So absolutely fantastic and welcome. And that's the benefit, I think, of having the virtual format. No one from overseas this time. And hopefully, I'm not sure if you can see the other question as well, but we've got some information regarding connection to lung transplantation. So again, a big welcome to all of our transplant patients, our supporters, carers, loved ones, supporters, everyone who's on the call today as well. And we thank you. So we might progress on. I think we were going to do a short presentation, but I think we might move to our second half, if I understand correctly, Wendy, from a chat. So I'll hand back to Bron to introduce Professor Greg Snell. Over to you, Bron.
Okay, thanks very much, Catherine. Greg Snell, our medical head of our program, probably needs not much introduction to most of you on the line here today. He's been head of the program for almost 30 years now, and is a well-known international as well as national speaker and researcher. And so he's going to do a presentation today that's actually about lung transplantation and COVID. And then following Greg, we're going to have Professor Glenn Westall, who's also well known to most of you on the line today. Glenn has also been with our program for many years, probably about 20, I think now, and he's highly recognised for his interest also in advanced lung disease and lung fibrosis, as well as lung transplantation, and also being the head of the paediatric program at the Alfred. So I'm going to hand over to Greg now, who will present his talk, and then Glenn can do his talk about the future. Thanks very much.
Everyone for joining in today, and thank you very much to Lungitude for giving us the opportunity to present our work. We're very proud of what we've done. Essentially, I'm talking about the present, which is obviously a lot about COVID, and producing an up-to-date talk for you. So essentially, lung transplants will be not as active this year. We're predicting 75 transplants, which is down from around the 100 mark we had been running. We have been creative. We've done our first liver-lung transplant. We've done a liver, pancreas and kidney transplant has followed a lung transplant, and that's been successfully done. And we've obviously had to change our clinics. And I'll talk more about what we've done, what the Alfred's done with COVID. I'll specifically talk about masks. I'll specifically talk about vaccination and the success of it, and the question about 3 that everyone wants to know. I'll talk about what's happened in the US and UK. I think there's some lessons there for us. And I will talk about the freedom, in inverted commas, that we're going to have when we hit the 70 and 80% mark. So the graph here is of the number of lung transplants per year, and you can see we're steadily increasing in transplants up to 2017-18 and running towards the 90 to 100 mark. The last couple of years have been pushed back, and that's been a combination of a lack of donors, really, and they relate a little bit to the way the ICU departments have handled cases, but also in terms of also the the families consenting. It's very difficult to consent when you can't go and visit an unfortunate dying relative or talk face to face with the doctors, and I think that will be probably continuing this year. In terms of how we gone overall with COVID lung transplant results, well, there's now been 2 cases, both here in this end of the country. One who had tummy symptoms and tiredness, and the lungs were never a trouble and got better. And one person recently with pneumonia who's got into big troubles and hasn't made it out the other side. This is still only 16% of that of the Australian general population's risk of COVID. So the bottom line is you guys have been holding out very well, hiding away, and done well from a COVID point of view. But obviously it's still a risky business, COVID. We are continuing with our clinics and telehealth, focusing obviously on lung troubles, but we can also see that there's been, it's not just about COVID. The problems we're facing at the moment are a combination of a bit of COVID, but it's more about people hiding away and our systems being shut down a bit. And we're seeing some urgent cases of serious skin cancers, bowel polyps and bowel bleeding, and causing troubles. And we can see that we're going to have troubles with blood pressure, diabetes, weight changes and things like that occur, dropping in lung function that's going to occur over time. So whatever COVID's going to do to us in the next 6 months, the concern is that we've got to stay connected to one another so that over the next few years we clean up all the mess that COVID's created. And of course the stress on everyone concerned. There's no question this is the biggest medical event for our lives. In terms of the Alfred, Alfred lung transplant team to start with, we've split up into different teams. So we're in different spots, so we're not cross-infecting one another if anyone were to get it. And I might say no staff has had COVID yet. So we've got a ward team, a telehealth team, and a face-to-face team, and we're now starting to do some COVID work as well. Mostly telehealth and phone and less face-to-face consults, which is not the way any of us prefer to work, but it's the way to get through, and I think it's a lesson we learned from last year. When we're connecting to you, we're connecting on Microsoft Teams and linking up with the nurses and the physios and social work and the like as we work from home or work here from the offices. I'll talk a bit about the face-to-face visits with people on the next slide, but essentially we're doing less breathing tests and less bronchoscopies as has been mentioned, and we're trying to use our country centres and the peripheral centres in Melbourne who can do breathing tests. So you might be hearing us talking about other places to go for a breathing test. We've used email. Obviously, everyone here is able to handle that, and we're sending out a huge amount of medications over the last 18 months. The Alfred is coping with COVID as one of Victoria's sort of lead COVID hospitals, and that's good because they're getting experience and it's being tackled very seriously. As I've mentioned, it's a struggle for us a bit as well. There's a big focus right from the top on this. There's a focus on screening, which we've all seen. We've got a pretty rapid turnaround of swabs, and if someone's coming in for a transplant, we can do a test in a couple of hours, although they're limiting us to the amount of acute testing. We're all wearing 95 staff masks when we're seeing patients. And the Alfred's also following a lot of cases in the community. I have to say it's getting serious. The Alfred is planning to have up to 330 beds devoted to COVID, 200 ward patients with 130 ICU patients. And at the moment, there's probably around about 70 or 80 COVID patients here. So there's no question this is serious. We're using separate wards, nurses, doctors for the COVID inpatients so that there's a physical separation. And a lot has been learnt over the last 18 months. We are starting to need to rotate some of our medical teams through COVID, and again, we're spacing them from any contact with transplant patients. And our staff are having to potentially learn how to work in other areas as things get serious. I thought I'd touch on the N95 masks, and the masks in particular. We're all familiar with seeing these different ones around, but the masks that the staff are wearing are individually fitted. You try about 6 or 7 different types and get one that absolutely fits and is shown not to leak. And when you wear it, you're not leaking any air anywhere, and they're really quite claustrophobic. And indeed, people are actually getting skin rashes and pressure areas from wearing the masks. And they're disposed of after 4 hours. You've got someone watching you wearing them, and essentially they do protect you from it. But these just aren't. You just don't buy anyone across the shelf. These are ones that specifically fit you. And that's quite a contrast to what's going on out in the community, where truthfully they're almost designed to leak. They're worn, on the top of the head, under the chin, half over the nose. I think sometimes they're hanging around for weeks. And as much as anything, they're to stop you from spraying stuff forward and protect others rather than perhaps you per se. So it's important to realise that the masks we're using are several levels up on what we were using 6 months ago, and certainly on what we were using 18 months ago. Vaccination. This is some Australian data from South Australia in kidney transplant patients versus probably the staff, in fact, probably the non-immune suppressed. And there's baseline before you have your Pfizer vaccine, then T2 when you have a dose of Pfizer, and then when you get your second dose. And you can see from the graph on the left that essentially you go from 1 up to 100 up to 1,000 if you're not immune suppressed. And the numbers are not as impressive for the kidney transplant patients here, where they're heading from sort of 1 up to about 10. So it's quite a difference in the effect. And the whole benefit of vaccination is not just limited to this graph, and it's a tenfold different. There's other ways the immune system benefits from the vaccine, but this is an example of how there may not be the greatest translation in vaccination in transplant patients. And this has led to the consideration of the third dose. And this is very recent information in transplant recipients in the US and the New England Journal of Medicine. And essentially it shows that if you're here using the Moderna virus, that when you give a third dose, the ones in red there do go up further, and you're heading towards the 1,000 mark there for that particular vaccine, and is definitely better than if you just sort of wait the time and don't have a placebo. And it's proving to be safe. And I've even seen stuff showing that there's some people getting 4 doses of vaccine and it's still safe. It's not stirring up the immune system and causing rejection, which is an important thing, and no one's had any major issues with it. There's discussions about the ethics of people missing out, but in reality, that's more about the way things are being distributed. Because in fact, 1.5 billion vaccine doses are now being made every month. And if there was a will, you could vaccinate everyone in the world between now and Christmas if you wanted to, with those sort of numbers. So I think this will come here. ATAGI is looking at it. I think they're waiting for people to get doses 1 and 2 down first. Is the vaccine safe? Well, the one we've worried about is the AZ vaccine, and I thought this was a particularly good graphic here, saying the risk of dying was a fraction of what it would be if you were rock climbing or scuba diving, or indeed your chances of dying with AstraZeneca is about that of being struck by lightning, literally, or having a car accident. Or if you're a lung transplant recipient living in the United Kingdom for the last 18 months, you had a 15,000 per million chance of dying. So the consideration in the UK of AstraZeneca vaccination versus being a lung transplant patient sitting at home was a very obvious which way you should be going with vaccination in terms of risk. If you tease that apart a bit, in fact, if that 15,000 is essentially made up mostly of those who are unvaccinated, with the group who had 1 vaccine dropping down dramatically, and indeed if you had 2, you were basically pretty safe, or at least a lot safer otherwise. Recognising that the overall UK death rate down there over the same period is 2,000 per million, which is importantly 40 times more people have died in the UK than have died in Australia. So for all the talk of all the lockdowns and all the dramas and what it's cost, we've saved around 39,000 Australian lives have been spared from COVID. So this is in the US and essentially describes how you go with particularly hospitalisation of COVID, and is pretty current. That per million, there's the population, the first black box, 267 per million people are being hospitalised with COVID. And the next big one shows that that's essentially the unvaccinated people, and the vaccinated ones are not the hospital cases. And if you look down the bottom there, there's just as comparators, cancers 210 in 2017, HIV, traffic accidents, and the influenza down the bottom there is, over a 9-year period, influenza was hospitalising, 26 per million. And you can see that that's essentially what it would be for vaccinated people. And I think that's where we're heading, to say we will end up living with this. We're not going to like it, but it will cause hospitalisation, will cause troubles. Almost exactly the same rate of US versus, compared to the UK, a death per million, with again almost exactly at 40 times the death rate. And again, we would have 39,000 extra deaths if we'd done what the UK had done. The US and the UK had done. So in terms of transplant patients getting COVID in general, what does the world experience tell us? Well, it's clearly a serious problem, best avoided. And there's 2 large studies just recently, one including quite a few lung transplant patients and one including a few lung transplant patients and mostly kidneys. And they do show you're more likely to be admitted to hospital. But very pleasingly, there's no increase in the use of oxygen or the extent of oxygen and in terms of dying. And it's actually the same as the general population. And what it turns out to be, the reason there's been all this discussion about it in some ways, is it's about picking up other diseases. Obesity, heart disease, kidney disease, diabetes, etc. They increase your risk. And so if you're well and these things are well controlled, then your risk is essentially the same as other people. And I think this is because there is some protective effect against the inflammation that is so devastating with COVID. And that the prednisolone and tacrolimus are both showing some actual benefit. On the other hand, coming into it immunosuppressed, there might be a bit more virus held by a transplant patient, so it might be a little bit more infectious to others around them, which is something to bear. Even if someone's got a mild problem in the community, they might be causing some troubles to their family. And in closing here, I'm going to talk about the Doherty model, which was used by the Burnett to produce a roadmap for Victoria as to what's going to happen. And these are a scary set of graphs. The little black line sort of coming up there is where we were at when this came out a few weeks ago. Next slide. You can see the cross is where we're at today, and we're actually on track now for the diagnoses per 7 days, per day to be about right. We had 17, we had 1,600, with something like that coming up on the first graph on the top left. And we're tracking on the average, that thicker blue line through the middle there. The other lines sort of bouncing off that are sort of the range at which it's possible. The 70 and 80% talk about the freedom from restrictions and freedom from lockdowns. And the problem is that once we come out of lockdown, you can see that those, whichever way we look at, we're going to have a rebound in cases, hospitalisation, ICU demand, and very scaringly, the last bottom one down there in cumulative deaths. And noting that in Victoria, we've had something like, I think it's something like 800 or 900 deaths. And according to what our state government's working off, they're expecting 2,000 deaths more by the 31st of January. So no question, we've got some adventures to come here from a medical point of view. How did they get at these figures? Is essentially this roadmap from the Doherty that's been used by the Australian federal government with a plan that was put together in August. And basically down the left side of the figure there, you can see 50, 60, 70, 80% vaccination rates. And the red is in the setting of a lockdown, and the graph overall is looking at costs. And you can see that at 50, 60%, and we're somewhere around there at the minute, there's a lot in the red. The lockdowns are costing a huge amount. Those figures there, $2 billion per week. But that goes down as you get to 70%, which is where we're aiming to come out of lockdown. And there's the least amount of money being spent on health capacity and illness when you get down to 80%. But it's still very substantive at $500 million a week being spent in Australia at 80% plus. So the graphs before, the blue graphs I showed you before, showed that what happens when we're coming out at 80%. But it's also clear that we've still got lots of adventures with lockdowns. We've still got restrictions, and we've still got a health impact to come on the back of this. So it's by no means over. And as I say, we're balancing medical capability with economic viability. So in summary, there's a lot happening at the Alfred. We're doing our very best to look after you. We've learned a lot over the last 18 months. There are models that are going to predict what's going to happen, but no one knows. And hopefully we're at the better end of those figures, not the average and certainly not the high one. I've got my fingers crossed. And thank you to everyone for your patience and support and flexibility as we've worked our way together through the last 18 months. Thank you.
So in the last 10 minutes or so, I'm just going to talk a little bit about our kind of strategic research direction for the next 3 years or so. I think that we're at a natural crossroads, not only because of the hiatus that COVID has impacted with regard to our ability to do research, but it was also a number of our projects that have been running over the last 3 years were coming to a natural close on the back of federal funding that we received 3 years ago to do these projects. So it was a timely moment to discuss really about what we want to do moving forward. And what I want to do over the next few slides is really just give you a little bit of a background of how we basically address this question about defining our research direction. It starts with, some really very simple questions, if you like, is, why are we doing research? And, it comes back to simple questions such as, how do you define success in lung transplantation? And we're aware that, it's really, at its bluntest, it's about saving lives, taking people who have got advanced lung disease, who are in essence in danger of dying, and taking them away from that cliff edge. It's actually more than that. It's actually about giving them their lives back. And it's not all merely about saving their lives. It's about returning them to where they were before they got their lung disease and having full and satisfying lives. And our research really keeps that in mind whenever we create our kind of research strategies. So how do we achieve success? And there's really two sides to this. It's about getting to transplant. It's about what happens after transplant. And getting to transplant is really all about access to lung transplantation. And that's about maximizing organ donation. It's about reducing death on the wait list. And really, what's critically important on the day of the transplant is really making sure that we are matching our recipient with the very best organ donor. And Lucy spoke a lot about this earlier on, in this concept of epilet matching, which is a research tool, but we hope to become a clinical reality pretty soon. And then on the other side of the equation is about prolonging survival after lung transplantation. And very simplest, that's really about defeating rejection and defeating infection. And again, Lucy alluded to this earlier on. When we look at access to lung transplantation, we really have world's best practice, and there's data that we've published that really shows this. We really do maximize organ donation, and on top right is some data that shows for every 100 donors that are offered, how many of them are we using? And our figures are 3 times that for the US, double that for Europe, and indeed higher from anywhere else within Australia. And this is important because what that means is that we make dramatic inroads into reducing waitlist mortality. And as I said, these are world best figures. Unfortunately, the reality of going on a waitlist is that not everybody gets to lung transplantation. And figures from the UK suggest that for every 3 patients who are added on a lung transplant waiting list, 1 of them will die, i.e. 33% waitlist mortality. And you can see that by being really aggressive in this space, we've made dramatic inroads to our own waitlist mortality, such that when we were putting people on the waitlist 10 years ago, we were having a conversation saying that 1 in 5 of you, unfortunately, won't get to transplant because of reduced access to organ donation. And with these research endeavors, we've really got that down to less than 5%, or figures of 1 in 20. And there's nowhere else in the world that has figures as good as that. What about the other side of the equation, prolonging survival after lung transplantation? And again, our research has made dramatic inroads as well as our clinical practice into this. And you can see here is some outcome data compared to registries that are collected from every other lung transplant unit in the world. And you can see that survival at the Alfred is significantly better than if you were transplanted in any other centre of the world. But you can also see that there is also much further room for improvement, and we want to get that line a lot higher than it currently is. So, we reflect, but we're very happy where we are, but we want to do better. And we also recognize that, having world's best practice is not achieved by chance alone. It's actually achieved by extending the boundaries of what is possible and forever not being complacent and asking, how can we do it better? And in essence, that is how we define research. And everything we talk to you about is really basically working out how can we do better to what we're currently doing and further improving our outcomes for our patients who are transplanted within our unit. So these, in essence, are our research priorities at a very simple level. They are about matching recipients with the best organ donor, and that, in essence, is what Lucy was talking about earlier on. It is about defeating rejection, and it is defeating infection so that we can have prolonged survival after lung transplantation. So this is a busy slide, but gives you an overview of kind of current research activity plus also envisioned research activity. And I've kind of split it into 4 different domains. I'm going to just spend a minute or so on each one of these domains. I'm going to start talking about what I talk kind of basically clinical research. And this is really how I define this is, in essence, a continuous critical analysis of how we deliver our care. And it's where we look at every single aspect of the transplant pathway from the very first point that we meet you in outpatients being considered for transplant, how we manage you on the wait list, how you are transplanted, who we choose for transplant, how we manage you in the ICU, in the ward, and as outpatients thereafter. And looking at every part of that and working at if we can do better at what we're doing. Can we better use our immunosuppression, our antibiotics? Can we deliver healthcare better, whether that's via telehealth, pathology in the community, hospital in the home? And it's not just medicine, it's a whole medical team. It's about nutrition, it's about physiotherapy, it's the whole allied health team, including social work. And what we've evolved to over 20, 30 years is that this research ethos is really embedded within every single member of the lung transplant team. So I don't want you to have the impression that we have an isolated research team. This research belief is completely embedded with every member of the team. And I think that there's no better example of this than us essentially documenting what we did as we went through the second wave of COVID last year. And Greg described some of the, what many of you have experienced, how we've essentially moved to a complete telehealth model for a period of time and are back in that space currently. But research is all about not only modifying what you do, but it's also publishing what you do so that not only do we have the benefits of how we improve, we can share that benefits. And our lung transplant nursing team basically put this together under the stewardship of Daniela and really described and put it into the international literature how we got through the first wave of COVID. And what was gratifying about this is that as New South Wales went into their major COVID wave earlier this year, the lung transplant team in Sydney were aware of this document and they reached out to us and said, can you please share your insights so that we can improve our own service? And that in essence is what research is all about. So changing tack to talking about clinical trials. Now, these are really major kind of clinical endeavors, invariably supported by industry and by pharma. And we attach ourselves to the projects that we think are going to improve the outcomes of our own patients. And I won't go into detail, but there are a number of ongoing as well as envisaged trials covering various aspects of lung transplant care. In the space of immunosuppression, we're talking about potentially a trial using inhaled tacrolimus. Many of you will be aware that if you've got asthma, we don't give you steroid tablets, we give you inhaled steroids. And there's been a lot of thought that rather than giving you tacrolimus tablets, why shouldn't we be giving you inhaled tacrolimus? So you potentially will be hearing a lot more about that in the future. We have ongoing trials looking at stem cells and photopheresis to manage chronic rejection. And we're looking at novel therapies for CMV and as well as antifungals. And I don't have the time now to discuss those, but more than happy to do at any future point. I'll finally just talk about immunoglobulin therapy. This is a trial that we're offering to people early post-transplant. This is an antibody. We think in many ways this is a perfect therapy. It's a therapy that can manage both sides of infection and rejection at the same time. There is evidence that it can help people avoid people getting rejection. It can help people fight infection. And most of our treatments are only often addressing one side of that equation. And I mention it because for us to establish this trial led to developing a relationship with CSL. And I think that we're very early on basically having ongoing discussions with CSL about really having a big picture, kind of blue sky, developing a therapeutic research alliance with CSL, moving beyond this specific trial, basically taking into account a number of synergies that we are both located in Melbourne. CSL is one of Australia's most successful companies. In fact, they have a lot of shared interests. They haven't always been interested in transplantation, but they are over the last couple of years. So we're at the very early stages of basically developing a medium to long-term relationship with them, where we basically look to co-develop novel therapeutics. And of course, this will be to the benefit of our patients. And we'll be hearing more of this once we've got through the lawyer stage. What about novel diagnostics? And again, you've already heard about some of this earlier on. Jay talking about FOT as a novel way of doing lung function. Lucy talking about epaulets and the relationship we have with Red Cross about finding new ways of defining compatibility between our donors and recipients. And this is a major theme where we're always trying to find better techniques to diagnose problems that we recognize post-transplant. I'll just spend a moment talking about what we're doing in the radiology space and the interactions we're having with a group called 4D Medical. Again, one of these themes, we look around who are the best at what they do in the local area, and 4D Medical are actually located in Melbourne, and they came out of a PhD from Monash by a guy called Andreas Furas, and he's developed essentially a 4D way of looking at imaging the lung. So we go away from kind of 2D imaging, which is the chest X-ray, where it's just a flat appearance. We then went on to CT scans, which in many ways is a 3D way of looking at. We can really get to appreciate the volume. And what they've developed is a technique where they can actually see how the lungs are modified between inspiration and expiration, how we breathe in and breathe out, and how the function changes. And there's a lot of interest here, and we've just signed off and have ethics approval to look at their technologies in some of our patients who are being assessed for transplant. And what we're hoping to do is design a study pretty soon about whether or not we can use it after transplant as a method for really picking up chronic rejection at a much earlier stage. And if we can do that, we can intervene at an earlier stage, again to the benefit of our patients. And then to finish off, I just really want to talk about translational or basic science. And this is really, I guess, I think a major announcement that I'm delighted to share with you, but to really come out of these discussions and how we're going to pivot moving forward. And this is that we're going to essentially, with Lungitude's backing and support, aim to establish our own lung transplant, what we call wet lab, based here at the Alfred. A lot of the research that you've seen being presented today and previously, we've often outsourced that to partners around the state or around the world, whether that's the Doherty Institute or other institutes. And we think there are efficiencies in actually bringing a lot of this expertise in-house. And we have only in the last few weeks established a lung transplant lab, and you'll be hearing a lot more from Sandra Stankovic, who is our first appointment. The principles of this is that it will be located at the Alfred within the Central Clinical School. It will be a real focus on translational science, doing research that will lead to better outcomes for our patients. It is part of an expanding respiratory research at Alfred portfolio that is being headed up by Anne Holland, who's recently been appointed to the head of respiratory research at the Alfred. And it will continue to build on our existing collaborations with our other labs within the Monash University framework, as well as maintain all of our current existing national and international collaborations, as well as looking for industry collaborations. And in setting it up, we've done it really with a very with a financial stability in mind, and ensuring that it's going to have legs and it's financially sustainable. And pleasingly, the university has come on board, and they've encouraged us to look beyond Victoria and beyond Melbourne to look out for the new wave of the future transplant immunologists, and with a view to recruiting the future stars who can further perform their science in-house here. What we'll be focusing on, well, a lot of it will be focusing on this cell called the T cell that you've heard about before. For those of you who take tacrolimus, this is the key drug that allows us to do transplants, and it is a key drug that switches off this T cell. But despite people taking tacrolimus, this T cell can still become active and can drive research. And we're really trying to better understand how we can harness and control this cell. And there's a number of studies that we're doing, and these are just the summaries, but in essence, they're the summaries of what Lucy presented to you all earlier on. And I won't go into any more detail about them, but these are all being run from this point moving forward. But we'll also continue with our current collaborations. We have a major interest on another immune cell called B cells. This produces antibodies and creates a clinical condition called antibody-mediated rejection. And that's an in-house collaboration with Dave Tarlington's lab, who's also based here at the Alfred. And we have a major interest in defeating chronic rejection, and a particular interest in how the lung microbiome might change. And you may have heard about the gut microbiome. But the lung also has a number of bugs, and there's healthy bugs and unhealthy bugs, and we're interested in whether or not that relationship is what leads to chronic rejection. And this is research that we're doing with Ben Marsden's lab. So I will leave it there. That really was a superficial overview, but I think we're at a very, very exciting crossroads. And certainly as we go beyond COVID, we'll be hearing a lot more about these projects. And once again, I thank Lungitude for their support in a lot of what I just presented. Thanks.
Thanks very much, Greg and Glenn, for your presentations. I think we've got a few questions there. Catherine, have we got a little bit of time to ask a few of them, do you think?
Yeah, look, I think maybe if we tackle 3 or so, and then we'll just wrap up, just respecting people's time who need to leave at the half hour. And then, as we said before, we've got the additional 15 minutes informal time for addressing questions for those who are able to stay. Is that okay, Bron?
Yep, that's fine.
Perfect.
One of the key sort of themes that's coming up is, does the type of immunosuppression drugs impact the response to the vaccine in transplant patients, and is one better than the other, and consideration to changes around the timing of vaccine to help boost protection. So maybe, Greg, do you want to sort of...
Thanks, Bron. I think it's a very good question. It's a reminder that the best immune system to have a vaccine work off is a normal immune system. So before transplant is the best time to get vaccinated with all of those things you can, like the shingles vaccine and pneumovax and stuff that protect against infections, and ideally now, of course, COVID vax. Afterwards, we have to have the immunosuppression to stop the lung playing up, and it's probably too dangerous to shift that down and drop that off. It does come up as a suggestion, or what if I had less mycophenolate or azathioprine, would I get a better response? Well, you might, but you'd also be risking rejection and stirring up a graft that then doesn't ever settle down again. COVID has been most associated has been a little bit more most associated with mycophenolate, but again, there's a good reason you're on it. So the aim is not to stop it, but as always, to be thinking about someone's risk. It's often asked, if we're stimulating the immune system, does a vaccine actually stir up rejection molecules and inflammation as well? And the answer is possibly. There's a little background, little twitch in there that you can see, but again, it's not something that we've seen specifically rejection afterwards, but is again a reminder that if we can take that out of the way by vaccinating people before transplant, it's the go.
Thanks, Greg. And there's another one that one of the patients has asked, what have we seen in regards to efficacy rate with the vaccines in our research? But we actually haven't. We have a study underway. Is this correct at the moment? Just looking at some patients who are contributing bloods post-vaccine, before and after their vaccine. Is that correct?
So we have a collaboration with we're collaborating with the infectious diseases group here who are tracking. I think we'd find similar results to the ones I showed on the graph from Toby Coates in South Australia on the kidney transplant patients, but we don't know exactly. And there's a reason we're not routinely measuring antibodies in everybody, is because that at the moment doesn't absolutely correlate with your risk of disease, and also currently we have no way of further supplementing it. And I think that probably we won't be looking at antibodies to decide who gets a third vaccine. We'll be just encouraging everybody when I think the government does let us do that.
Okay.
Can I suggest there's the one question I think is really useful for everyone to hear, which may relate to Glenn's presentation a little bit more. The one saying, amazing work on successful transplantation survival rates. What are the barriers to be able to do more research for higher success with the transplant team? Is it access to data, funding, or time? I think that might be a useful one to address.
Money. Sadly, Sadly, it is funding. The funding environment is pretty unpleasant in Australia. The major way you get funding is by applying to the federal government, and you have Australia's very best all competing for that pot of money, and the success rate is around about 7%. So less than 1 of 10 of brilliant research proposals get funded. And unfortunately, they often go to the high-profile areas of, pick your choice: heart disease, breast cancer, prostate cancer. Lung transplant often isn't seen a priority, and that's to the detriment of our chances in getting funding. And that's why we're incredibly reliant and for the funding that we get from Lungitude and from other sources.
I think it's also got to be recognised that behind the scenes is a lot of work to even start these things and then complete them. There's a huge amount of regulatory process, entirely reasonable. We have to be legal, we have to be ethical, we have to be moral, and there's got to be scientific evidence behind it. But that takes setup, and when you put in an application to the hospital to study an idea, just to put the application is around 100 pages of information, even seemingly on a simple thing, and it can take many months to get it through the system to get complete agreement.
Perfect. So, Bron, if it's all right, we might just end the formal questions there, but just as a reminder to those who are able to stay that we will have the panelists available, and we'll go through the questions that remain unanswered. But yeah, great message there, that huge amount of effort and funding, and that's why the support that many of you on this call provide is just so critical to enable the Alfred team to remain one of the best in the world in terms of the outcomes for transplant patients. So I think at this point now we'll do a couple of brief closing pieces and little housekeeping points. But the first is, I think I'm going to hand to Gordon Jenkins.
With a great pleasure that I have a big check to donate to the team. I want to say, first of all, a massive thank you to Wendy, Bron and Catherine for a great presentation today, and obviously everyone that presented, well done. So I have an enormous check here for $160,000, which by the world of miracles, this is now going to get passed over to Greg. So Greg, get ready to collect this. Off you go. And hopefully...
Oh, here it is. Yes.
Hey!
So I'd like to thank Wendy, Gordon, and all of the Lungitude crew, and all of the supporters, and indeed all of the patients who've contributed for helping with this. This goes a long way towards setting up the ongoing base of staff and equipment and that Glenn was talking about. So thank you to everybody, and we really appreciate the generosity, and we really will do our very best to pay back the kind thoughts and the gift. Thank you.
Thank you. And obviously, if anyone's listening wants to help, as Glenn said, raise provide any funds, and obviously through Lungitude we can make sure that the funds go to the right research projects, and obviously keep the team accountable that they deliver on the research projects.
Fantastic. Thanks, Gordon. Great. What a great piece of technology that we're now able to send checks virtually so efficiently. So thank you. So now it comes to just closing the session today, and I appreciate some people may need to drop off as we're slightly over time, so apologies for that. But firstly, just to touch on, it's a big month for us, October. We've got the virtual challenge, which is a mechanism for us to do some fun things, but also to raise money for this great research that you've just heard about today. So the Lungitude Virtual Challenge will take place between the 9th and the 17th of October, and replaces what we used to do with the Melbourne Marathon. So here's your opportunity to either participate and do whatever you like. As you can see there on the slide, run, walk, hop, skip, whatever it is that you'd like to do, and encourage some people to sponsor you for your efforts. Obviously, all of these funds go towards the great research work that you've just heard about today, and what will happen in the future as well. A big thanks, firstly, today to our presenters. I think Gordon already touched on this, but the presenters today are really quality presentations, and it's quite an art to be able to present a complex science in a way that the majority of us can understand. So a big thanks. And beyond that, thank you, more importantly, for the work that you continue to do, the care you show for the patients, and your relentless pursuit to improve things for patients. Absolutely outstanding, and it's your passion and drive, which is so critical to all of this. So thank you for that. To all of our supporters, I think we just had the slide there, but again, all of the work would be impossible without the key supporters there, and particularly some of our big family supporters. So a big thanks. We also have a number of anonymous supporters. So a big thanks to every single one of you who contribute, no matter how small or large. We're very, very grateful. Just on behalf of the board, so I don't think I mentioned my name before. I'm Catherine Turkle. I'm here representing the board together with Bronwyn. A big thanks to the board who largely volunteer their time to support the endeavours of Lungitude as well. So a big thanks to fellow board members, many of whom are online today as well. And I should mention committee members as well, fundraising committee members, etc. Everyone does this out of pure passion and wanting to improve outcomes. So a big thanks to everyone there. Finally, just a little bit of housekeeping. So there was a question, I think, in the chat as well. This session is being recorded, and I apologise. I probably should have said that at the start, so people know that. But this session's being recorded and will be available hopefully fairly soon. You'll get an email. So if you wish to review the information again, you'll have the opportunity to do so. There will also be a survey just asking for your feedback on the session today. Like the researchers, we're trying to relentlessly pursue better sessions for you to deliver on what's helpful for you. So please do provide very candid feedback, the good, the bad, whatever you think we can do differently to make this even better for you in the future. And there will also be the new impact report, I think, available from this Friday. So a lot of resources and opportunities for you to engage with what's going on with Lungitude as well. So a big thanks. You can contact us at any time. And one final thank you to Wendy, who's been the mastermind behind all of the technical aspects of today. We had a couple of technical issues, but actually nothing major, and that's thanks to the great work that Wendy's done in doing the preparation and everything as well. So I think that's it in terms of the formal session. A big thanks. Those who wish to stay online for the further informal Q&A session for the next 10 or so minutes, welcome to stay, but certainly respect many people may need to leave. So a big thanks from us, and well done to our presenters. And thanks to all of our attendees as well from all over Australia. Thank you very much. So I think that closes the formal session. So maybe now, Bron, we can go back for those who are able to stay to the remaining questions that are in the Q&A section and in the chat. Just checking that you're still there. Yep.
I'm here.
Perfect. Right. So back to you.
Yeah, I was just having a look at. There's one here for Lucy that is I think waiting to be answered. Is it better for the recipient to be CMV positive? And I think that's a good question.
Yeah, it's an excellent question, and I would say that would also depend on your donor. So if your donor has, well, first up, the best outcomes in terms of CMV is when you have a donor who's negative and a recipient who's negative. So in that case, it's best for the recipient to be CMV negative. However, if your donor is positive, it is better for you to be positive because your immune system has already seen CMV and has some memory to it. So therefore can fight the virus a bit better had you have not had seen it before.
Okay, thanks. There's a few questions. One from one of a previous question. Is a child's life expectancy post-transplant still only 6 to 8 years, or now is it now higher? And that's one of our mums from one of our paediatric patients, actually. So maybe, Greg, do you want to answer that question?
Yes, I think historically children with transplants have been pretty tough, often because they've been referred fairly late, and so you've got the baggage of being really sick for a long time before coming into a transplant. The future should see earlier referrals and better drugs, and I think starting to understand that the risk time for children having transplants is through adolescence. So that might well be 3-5 years into the transplant, and making sure that in the end you're getting proper care through all of that period and out the other side. So you would expect it to improve over the years. but there still is a gap in adolescence that marks the low point of a lower point of survival. And the best transplants are done sort of younger and older than that, to be honest. But we're working on that too.
Okay, thanks. And I'm just looking back here. There's a few more about that relate to the understanding a bit more about feedback on the various vaccines and the impact on lung transplant recipients. I can say maybe we can provide that. We just recently did a survey of our lung transplant patients and asking who had been vaccinated, and that will have some feedback that we can put out in a newsletter, hopefully in the next few days. I don't know if there's anything else you want to add, Greg, for that.
Yeah, we've found out that we believe a very high proportion of our patients double vaccinated. A very high proportion have come in relatively early to the vaccination with AstraZeneca, and I think AstraZeneca is proving to be perhaps a solid performer as the months pass, and Pfizer's perhaps proving less of a performer. And this leads to the question of having a third dose of something. So there's no problems with the AstraZeneca that we've seen. In fact, we haven't had any major problems with any vaccination that we're aware of, which is good, and again may be helped slightly by the immune suppressing drugs, ironically. So I think it's and we're not seeing any difference. I think if in the ideal world, maybe the Moderna might be the next variant on top of it, to next medicine to go on top of it, or the Johnson & Johnson. So something different with a slightly different approach rather than three of the same. So watch this space, but it's the vaccination side's gone well, I feel, and has been a major help to people.
Okay. Now there is a couple in the chat. Okay. Oh, there was one about inhaled tacrolimus and whether or not where's that gone? That may have been answered. About it's improving the ability to reduce skin cancers, etc., having it inhaled rather than taking it orally. Do you think that has an impact? Will have an impact?
I think using an inhaled drug really does have the thought that it will stop the side effects of the immunosuppression, literally in terms of infections, but certainly in terms of kidneys and skin changes and cancer changes and stuff that might be associated with our drugs, if you can give it locally. And it's just like putting a skin cream on a local red area versus having to have a bath in it. It's going to have a subtler effect. But so we're very interested in it, but it's going to be that again needs to be studied, needs to be understood. But that's certainly a target for us.
There was just looking back through the chat. There was a couple of questions back in there that I think we missed earlier on.
Just while you're doing that, Bron, I can see someone asked about how many people attended, so I'll just answer that question. It was, I think we had a maximum of around 127 or close to 130 people attending the call, so I'm not sure if the person who asked that question is still on, but great attendance, so thank you.
There's one question: is the epaulet biopsy the same as what is taken during the bronch? So I think that's something that you better.
So the epaulet story is the degree of matching, and you get that on comparing your blood with the donor's blood, and then working out the degree of difference. And if anything, the biopsies that Lucy was talking about there are aimed at seeing whether the body is disagreeing with the organ and trying to attack it, and you're looking for inflammation in the biopsies. And the trouble we've got at the moment is they're pretty complicated to do, and what we'd like as much as possible is to use a blood test or a breathing test, as we talked about. But if we have to do a biopsy, we want to do the least amount as possible. And as I said, as we go forward, if we can use blood tests, if we can use breathing tests and use the knowledge of the epaulet matching that occurred, then we may be able to better work out which drugs people need to be on and try and avoid all the extra mucking around with biopsies.
Thanks, Greg. There was one question in chat there about I think, did you answer that about it being recorded, the presentation being recorded? Yes.
Yes, I did. Thank you. Yeah.
Okay, thanks. I think we've pretty much covered everything that's there.
I'm not sure. What about the, unless I missed it, Brian, the question on, do you know of research in phages with transplant? So I'm not sure, unless I missed that being raised.
So phages, that's a high-tech question.
Yes, I missed that one.
Essentially, phages are very simple bacteria that are so simple that they can actually kill off other organisms, viruses and the like, but they're not dangerous per se in themselves. And using phages is being suggested as a way to kill some of the really difficult infections like the cousins of tuberculosis, or some of the funguses, or some of the very resistant bugs. And in very small things around the world that's been done. And our infectious diseases colleagues are looking at that for particularly children's infections. So that's very high tech and very interesting. Then they'd make a phage, or they'd find a phage that was specific for your bug that could kill it, your virus, your bacteria that you've got, and you'd be administered, maybe inhaled one, and it would fix it. So that's interesting.
Very interesting. I'm not sure, Brondy, there are a couple of others I wasn't sure if we covered completely, but we're probably just about at time. I think some of the remaining questions may be from patients, and I would absolutely encourage you to approach Bron or the team if you've got any remaining questions through your normal contacts. I did, if that's all right, Bron, is that all right with the team?
Fine.
And just as before we close, I just note there's some fantastic comments from people in the Q&A and in the chat saying absolutely fantastic presentation. Commendations, thanks from Liz Giddis, and a big thanks to Liz for the work that she does on the committee. There's I hope Kerry doesn't mind me mentioning her name, whose daughter's awaiting a transplant, and they've already raised $6,000 for the virtual challenge this weekend. To help towards hopefully new lungs for next year. So a big thanks to Kerry, and well done, and fingers crossed everything works well there. But I think we might leave it there, just aware that our panelists probably need to get back to their clinical work and seeing patients and other things as well, and all of you as well. So a big thanks again for today. Thank you for staying on for the additional questions to our panelists. Great session. So we look forward to catching up soon, and good luck for the virtual challenge for those who are starting that soon. Big thanks, and signing off now. Thank you.
Thanks, Catherine. See you, everyone.
Bye. Thank you.